Welcome to This Week in Surgery, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Surgery has you covered. Our podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the surgical field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Surgery, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine, including in the operating room. This week in surgery, we will be discussing recently published articles. First, Annals of Surgery. Impact of perioperative immunonutrition on postoperative outcomes for patients undergoing head and neck or gastrointestinal cancer surgeries, a systematic review and meta-analysis of randomized controlled trials. Objective: to clarify whether perioperative immunonutrition is effective in adult patients with or without malnutrition undergoing elective surgery for head and neck, HAN, or gastrointestinal, GI cancers. Background: it is important to avoid postoperative complications in patients with cancer as they can compromise clinical outcomes. There is no consensus on the efficacy of perioperative immunonutrition in patients with or without malnutrition undergoing HAN or GI cancer surgery. Materials and methods. We searched Medline, PubMed, Medline, OVID, Embase, Cochrane Central Register of Controlled Trials, Web of Science Core Selection, and InCare from 1981 to 2022 using search terms related to immunonutrition and HAN or GI cancer. We included randomized controlled trials. Intervention was defined as immunonutritional therapy including arginine and 3-omega fatty acids, or glutamine during the perioperative period. The control was defined as standard nutritional therapy. The primary outcomes were total postoperative and infectious complications, defined as events with a Clevin-Dindo classification grade greater than or equal to 2 that occurred within 30 days after surgery. Results: of the 4,825 patients from 48 included studies, 19 had upper GI cancer, 9 had lower, and 8 had mixed cancer, whereas 12 had HAN cancers. Immunonutrition reduced the total postoperative complications, relative risk ratio, 0.78, 95% C, 0.66 to 0.93, certainty of evidence, high, and infectious complications, relative risk ratio, 0.71, 95% C, 0.61 to 0.82, certainty of evidence, high, compared with standard nutritional therapy. Conclusions: nutritional intervention with perioperative immunonutrition in patients with HAN and GI cancer significantly reduced total postoperative complications and infectious complications. Unspoken truths: mental health among academic surgeons. Objective: to characterize the current state of mental health within the surgical workforce in the United States. Background: mental illness and suicide is a growing concern in the medical community, however, the current state is largely unknown. Methods: cross-sectional survey of the academic surgery community assessing mental health, medical error, and suicidal ideation. The odds of suicidal ideation adjusting for sex, prior mental health diagnosis, and validated scale screening for depression, anxiety, post-traumatic stress disorder, PTSD, and alcohol use disorder were assessed. Results: of 622 participating medical students, trainees, and surgeons, estimated response rate equals 11.4% to 14.0%, 26.1%, 141,539, reported a previous mental health diagnosis. In all, 15.9%, 83,523, of respondents screened positive for current depression, 18.4%, 98,533, for anxiety, 11.0%, 56,510, for alcohol use disorder, and 17.3%, 36,208, for PTSD. Medical error was associated with depression, 30.7% versus 13.3%, p less than 0.001, anxiety, 31.6% versus 16.2%, p equals 0.001, PTSD, 12.8% versus 5.6%, p equals 0.018, and hazardous alcohol consumption, 18.7% versus 9.7%, p equals 0.022. Overall, 13.2%, 73,551, of respondents reported suicidal ideation in the past year and 9.6%, 51,533, in the past 2 weeks. On adjusted analysis, a previous history of a mental health disorder, AOR, 1.97, 95% C, 1.04 to 3.65, p equals 0.033, and screening positive for depression, AOR, 4.30, 95% C, 2.21 to 8.29, p less than 0.001, or PTSD, AOR, 3.93, 95% C, 1.61 to 9.44, p equals 0.002, were associated with increased odds of suicidal ideation over the past 12 months. Conclusions. Nearly 1 in 7 respondents reported suicidal ideation in the past year. Mental illness and suicidal ideation are significant problems among the surgical workforce in the United States. Long-term outcomes of robot-assisted versus laparoscopic surgery for colon cancer, a nationwide register-based cohort study. Objective: to determine long-term survival in patients undergoing robot-assisted surgery, RAS, or laparoscopic surgery, LAS, for colon cancer. Background: the potential long-term benefits of RAS compared with LAS for colon cancer are not well examined. Using a register-based approach, we aim to compare these two surgical platforms in an analysis of long-term outcomes, including recurrence-free survival and all-cause and colon cancer-specific mortality. Methods: a nationwide register-based cohort study of patients with Union for International Cancer Control Stage I3 colon cancer undergoing planned RAS or LAS from 2010 through 2018. Patient demographic, clinical, and pathological data were retrieved from Danish national registers. Survival and recurrence rates were estimated by Cox proportional hazard multivariate regression analysis adjusting for baseline covariates. Results: a total of 7,565 patients, LAS equals 6905, 91%, and RAS equals 660, 9%, were included in the complete case survival analysis. Patients undergoing LAS had a significantly increased risk of cancer recurrence, LAS equals 1178, 17.1%, RAS equals 82, 12.4%, p equals 0.002, with a mean follow-up time of 4.93 years, standard deviation 2.47. The survival analysis of recurrence-free survival favored RAS, hazard ratio adjusted equals 0.80, 95% C, 0.64 to 1.00, p equals 0.049. No associations between the two surgical platforms were evident regarding all-cause, hazard ratio adjusted equals 0.98, 95% C, 0.82 to 1.17, p equals 0.783, or colon cancer-specific mortality, hazard ratio adjusted equals 0.89, 95% C, 0.67 to 1.18, p equals 0.405. Conclusions: adopting RAS for colon cancer was associated with improved recurrence-free survival. However, it did not cause a lower all-cause or colon cancer-specific mortality. A transcriptomic approach to understand patients' susceptibility to pneumonia after abdominal surgery. Objective: to describe immune pathways and gene networks altered following major abdominal surgery and to identify transcriptomic patterns associated with postoperative pneumonia. Background: nosocomial infections are a major healthcare challenge, developing in over 20% of patients aged 45 or over undergoing major abdominal surgery, with postoperative pneumonia associated with an almost 5-fold increase in 30-day mortality. Methods: from a prospective consecutive cohort, N equals 150, undergoing major abdominal surgery, whole blood RNA was collected preoperatively and at 3 time points postoperatively, 2 to 6, 24, and 48 hours. 12 patients diagnosed with postoperative pneumonia and 27 matched patients remaining infection-free were identified for analysis with RNA sequencing. Results: compared to preoperative sampling, 3,639 genes were upregulated and 5,043 downregulated at 2 to 6 hours. Pathway analysis demonstrated innate immune activation with neutrophil degranulation and toll-like receptor signaling upregulation alongside adaptive immune suppression. Cell type deconvolution of preoperative RNA sequencing revealed elevated S100A8/9 high neutrophils alongside reduced naive CD4 T cells in those later developing pneumonia. Preoperatively, a gene signature characteristic of neutrophil degranulation was associated with postoperative pneumonia acquisition, P equals 0.00092. A previously reported sepsis response signature, SRSQ, score, reflecting neutrophil dysfunction and a more dysregulated host response, at 48 hours postoperatively, differed between patients subsequently developing pneumonia and those remaining infection-free, P equals 0.045. Analysis of the novel neutrophil gene signature and SRSQ scores in independent major abdominal surgery and polytrauma cohorts indicated good predictive performance in identifying patients suffering later infection. Conclusions: Major abdominal surgery acutely upregulates innate immune pathways while simultaneously suppressing adaptive immune pathways. This is more prominent in patients developing postoperative pneumonia. Preoperative transcriptomic signatures characteristic of neutrophil degranulation and postoperative SRSQ scores may be useful predictors of subsequent pneumonia risk. Predicting outcomes following endovascular abdominal aortic aneurysm repair using machine learning. Objective: to develop machine learning (ML) models that predict outcomes following endovascular aneurysm repair (EVAR) for abdominal aortic aneurysm (AAA). Background: EVAR carries non-negligible perioperative risks, however, there are no widely used outcome prediction tools. Methods: the National Surgical Quality Improvement Program targeted database was used to identify patients who underwent EVAR for infrarenal AAA between 2011 and 2021. Input features included 36 preoperative variables. The primary outcome was 30-day major adverse cardiovascular event, composite of myocardial infarction, stroke, or death. Data were split into training, 70%, and test, 30%, sets. Using tenfold cross-validation, 6 ML models were trained using preoperative features. The primary model evaluation metric was area under the receiver operating characteristic curve. Model robustness was evaluated with calibration plot and Breyer score. Subgroup analysis was performed to assess model performance based on age, sex, race, ethnicity, and prior AAA repair. Results: overall, 16,282 patients were included. The primary outcome of 30-day major adverse cardiovascular event occurred in 390, 2.4% patients. Our best performing prediction model was XGBoost, achieving an area under the receiver operating characteristic curve, 95% C, of 0.95, 0.94 to 0.96, compared with logistic regression, 0.72, 0.70 to 0.74. The calibration plot showed good agreement between predicted and observed event probabilities with a Breyer score of 0.06. Model performance remained robust on all subgroup analyses. Conclusions: our newer ML models accurately predict 30-day outcomes following EVAR using preoperative data and perform better than logistic regression. Our automated algorithms can guide risk mitigation strategies for patients being considered for EVAR. Next article is from Journal of American Medical Association Surgery. Year-over-year ventral hernia recurrence rates and risk factors. Importance: recurrence is one of the most challenging adverse events after ventral hernia repair as it impacts quality of life, utilization of resources, and subsequent need for re-repair. Rates of recurrence range from 30% to 80% after ventral hernia repair. Objective: to determine the contemporary ventral hernia recurrence rate over time in patients with previous hernia repair and to determine risk factors associated with recurrence. Results: among 29,834 patients with MESH, the mean SD age was 57.17, 13.36 years, and 14,331 participants, 48.0%, were female. Among 5,599 patients without mesh, the mean SD age was 51.9, 15.31 years, and 2,458 participants, 43.9%, were female. When comparing year-over-year hernia recurrence rates in patients with and without prior mesh repair, respectively, the Kaplan-Meier analysis showed a recurrence rate of 201 cumulative events with 13,872 at risk, 2.8%, versus 104 cumulative events with 1,707 at risk, 4.0%, at 6 months, 411 cumulative events with 4,732 at risk, 8.0%, versus 184 cumulative events with 427 at risk, 32.6%, at 1 year, 640 cumulative events with 1,518 at risk, 19.7%, versus 243 cumulative events with 146 at risk, 52.4%, at 2 years, 731 cumulative events with 670 at risk, 29.3%, versus 258 cumulative events with 73 at risk, 61.4%, at 3 years, 777 cumulative events with 337 at risk, 38.5%, versus 267 cumulative events with 29 at risk, 71.2%, at 4 years, and 798 cumulative events with 171 at risk, 44.9%, versus 269 cumulative events with 19 at risk, 73.7%, at 5 years. Higher body mass index, immunosuppressants, incisional and peristomal hernias, a robotic approach, greater hernia width, use of a biologic or resorbable synthetic mesh, and complications, such as surgical site infections and reoperation, were associated with higher odds of hernia recurrence. Conversely, greater mesh width, myofascial release, and fascial closure had lower odds of recurrence. Hernia type was the most important variable associated with recurrence. Conclusions and relevance in this study: the 5-year recurrence rate after ventral hernia repair was greater than 40% and 70% in patients with and without mesh, respectively. Rates of ventral hernia recurrence increased over time, underscoring the importance of close, long-term follow-up in this population. Development and validation of the scoring system of appendicitis severity 2.0. Importance when considering non-operative treatment in a patient with acute appendicitis. It is crucial to accurately rule out complicated appendicitis. The A.I.O score, also referred to as the scoring system of appendicitis severity, SAS, has been designed to differentiate between uncomplicated and complicated appendicitis but has not been prospectively externally validated. Objective: to externally validate the SAS and, in case of failure, to develop an improved SAS 2.0 for estimating the probability of complicated appendicitis. Design, setting, and participants. This prospective study included adult patients who underwent operations for suspected acute appendicitis at 11 hospitals in the Netherlands between January 2020 and August 2021. Main outcomes and measures: appendicitis severity was predicted according to the SAS in 795 patients, and its sensitivity and negative predictive value, NPV, for complicated appendicitis were calculated. Since the predefined targets of 95% for both were not met, the SAS 2.0 was developed using the same cohort. This clinical prediction model was developed with multivariable regression using clinical, biochemical, and imaging findings. The SAS 2.0 was externally validated in a temporal validation cohort consisting of 565 patients. Results: in total, 1,360 patients were included, 463 of whom, 34.5%, had complicated appendicitis. Validation of the SAS resulted in a sensitivity of 83.6%, 95% C, 78.8 to 87.6, and an NPV of 85.0%, 95% C, 80.6 to 88.8, meaning that the predefined targets were not achieved. Therefore, the SAS 2.0 was developed, internally validated, C statistic, 0.87, 95% C, 0.84 to 0.89, and subsequently externally validated, C statistic, 0.86, 95% C, 0.82 to 0.89. The SAS 2.0 was designed to calculate a patient's individual probability of having complicated appendicitis along with a 95% C. Conclusions and relevance in this study. External validation of the SAS fell short in accurately distinguishing complicated from uncomplicated appendicitis. The newly developed and externally validated SAS 2.0 was able to assess an individual patient's probability of having complicated appendicitis with high accuracy in patients with acute appendicitis. Use of this patient-specific risk assessment tool can be helpful when considering and discussing non-operative treatment of acute appendicitis with patients. Next, we will be discussing articles from British Journal of Surgery. Surgical stress response in robot-assisted versus laparoscopic surgery for colon cancer, SURIRALS, randomized clinical trial. Background. Evidence for the routine use of robotic technology and its impact on short-term outcomes in colon cancer surgery is lacking. The aim of this study was to compare the surgically induced systemic stress response and clinical and patient-reported outcomes for patients undergoing robot-assisted or laparoscopic colon cancer surgery. Methods. In this double-blinded superiority RCT completed between August 2021 and March 2023, patients with stage 1 to 3 colon cancer were randomized in a 1:1 ratio to undergo either robot-assisted or laparoscopic colon cancer surgery. The primary outcome was changes in the systemic stress response, characterized by C-reactive protein expression in the first 3 postoperative days. Secondary outcomes were intraoperative and postoperative complications and patient-reported outcomes. The latter included quality of recovery 15 and pain intensity using a visual analog scale. Results. In total, 128 patients were screened for potential inclusion in this study, 50 patients, 25 in the robot-assisted group and 25 in the laparoscopic group, were included in the final follow-up and analysis. The postoperative C-reactive protein response was higher on the first postoperative day in the laparoscopic group, mean difference equals 19.88 mg/L, 95% CI 3.89 to 35.86, p equals 0.045. No statistically significant differences were noted for C-reactive protein expression on the second and third postoperative days. Conclusion. Adopting robot-assisted surgery for stage 1 to 3 colon cancer is associated with a reduction in the surgical stress response. Next we will be discussing articles from Journal of Vascular Surgery. A single-center experience of type B aortic intramural hematoma. Objective. The outcomes of the best medical treatment, BMT, and intervention treatment, INT, in a single-center experience were reported in type B intramural hematoma, IMH. Methods. From February 2015 to February 2021, a total of 195 consecutive patients with type B IMH were enrolled in the study. The primary endpoint was mortality, and the secondary endpoints included clinical and imaging outcomes. The clinical outcomes were aortic-related death, retrograde type A aortic dissection, stent graft-induced new entry tear, endoleak, and reintervention. The imaging outcome was evaluated through the latest follow-up computed tomography angiography, which included aortic rupture, aortic dissection, aortic aneurysm, rapid growth of aortic diameter, newly developed or enlarged penetrating aortic ulcer or ulcer-like projection, ULP, and increased aortic wall thickness. Kaplan-Meier curves were used to assess the association between different treatments. Results. Among the enrolled patients, 115 received BMT and 80 received INT. There was no significant difference in early, 1.7% versus 2.5%, p equals 1.00, and midterm all-cause death, 8.3% versus 5.2%, p equals 0.42, between the BMT and INT groups. However, patients who underwent INT were at risk of procedure-related complications such as stent graft-induced new entry tear and endoleaks. The INT group was associated with a profound decrease in the risk of ULP, including newly developed ULP, 4.3% versus 26.9%, p less than 0.05, ULP enlargement, 6.4% versus 31.3%, p less than 0.05, and a lower proportion of high-risk ULP, 10.9% versus 45.6%, p less than 0.05. Although there was no significant difference in the incidence of IMH regression between the two groups, the maximum diameter of the descending aorta in patients receiving INT was larger compared with those treated with BMT. Conclusions. Based on our limited experience, patients with type B IMH treated with BMT or INT shared similar midterm clinical outcome. Patients who underwent INT may have a decreased risk of ULPs, but a higher risk of procedure-related events, and patients on BMT should be closely monitored for ULP progression. Development of a comorbidity index for patients undergoing abdominal aortic aneurysm repair. Background: endovascular aneurysm repair, EVAR, and open surgical repair, OSR, are two modalities to treat patients with abdominal aortic aneurysm, AAA. Alternative to individual comorbidity adjustment, a summary comorbidity index is a weighted composite score of all comorbidities that can be used as standard metric to control for comorbidity burden in clinical studies. This study aimed to develop summary comorbidity indices for patients who underwent AAA repair. Methods. Patients who went under EVAR or OSR were identified in National Inpatient Sample, NIS, between the last quarter of 2015 to 2020. In each group, patients were randomly sampled into experimental, 2/3, and validation, 1/3 groups. The weights of the Lickshauser comorbidities were determined from a multivariable logistic regression, and single comorbidity indices were developed for EVAR and/or groups, respectively. Results. There were 34,668 patients underwent EVAR, 2.19% mortality, and 4,792 underwent OSR, 10.98% mortality. Both comorbidity indices had moderate discriminative power, EVAR-C statistic, 0.641, 95% confidence interval, C, 0.616 to 0.665, OSR-C statistic, 0.600, 95% C, 0.563 to 0.630, and good calibration, EVAR-Breyer score, 0.021, OSR-Breyer score, 0.096. The indices had significantly better discriminative power, DeLong p less than 0.01, than the Lickshauser Comorbidity Index, ECI, EVAR-C statistic, 0.572, 95% C, 0.546 to 0.597, OSR-C statistic, 0.502, 95% C, 0.472 to 0.533. For internal validation, both indices had similar performance compared with individual comorbidity adjustment, EVAR DeLong p equals 0.650, OSR DeLong p equals 0.431. These indices demonstrated good external validation, exhibiting comparable performance to their respective validation groups, EVAR DeLong p equals 0.891, OSR DeLong p equals 0.757. Conclusions. ECI, the comorbidity index formulated for the general population, exhibited suboptimal performance in patients who underwent AAA repair. In response, we developed summary comorbidity indices for both EVAR and OSR for AAA repair, which were internally and externally validated. The EVAR and OSR comorbidity indices outperformed the ECI in discriminating in-hospital mortality rates. They can standardize comorbidity measurement for clinical studies in AAA repair, especially for studies with small samples such as single institute data sources, to facilitate replication and comparison of results across studies. Duplex ultrasound and cross-sectional imaging in carotid artery occlusion diagnosis. Objective: investigations into imaging modalities and the diagnosis of extracranial carotid artery occlusion, CAO, have raised questions about the intermodality comparability of duplex ultrasound, DUS, and cross-sectional imaging, CSI. This study examines the relationship between DUS and CSI diagnoses of extracranial CAO. Results. Of our 140-patient cohort, 95 patients, 67.9%, had DUS follow-up, mean, 42.7 plus or minus 31.3 months. At index duplex, 68.0% of individuals, n equals 51, were asymptomatic. 75 patients, 53.6%, had CSI of the carotids after DUS-CAO diagnosis, 24%, underwent magnetic resonance imaging, and 76%, underwent computed tomography. Indications for CSI included follow-up of DUS findings of carotid stenosis/occlusion, 44%, stroke/transient ischemic attack, 16%, other symptoms, 12%, preoperative evaluation, 2.7%, unrelated pathology follow-up, 9.3%, and outside institution imaging with unavailable indications, 16%. When comparing patients with CSI and those without, there were no differences with regard to symptoms at diagnosis, prior neck interventions, or hypertension. There was a significant difference between cross-sectionally imaged and non-imaged patients and antihypertensive medications, 72% versus 53.8%, p equals 0.04. Despite initial DUS diagnoses of carotid occlusion, 10 patients, 13.3%, ultimately had CSI indicating patent carotids. 4 of these 10 patients had stenosis of 99%, with one string sign, 4 of 70% to 99%, 1 of 50% to 69%, and 1 of less than 50% on CSI. The majority of patients, 70%, had CSI within 1 month of the index ultrasound. There were no significant relationships between imaging discrepancies and body mass index, heart failure, upper body edema, carotid artery calcification, and neck hardware. 8 individuals, 10.7%, underwent ipsilateral revascularization, 62.5%, and equals 5, were carotid endarterectomy procedures, and the remaining 3 procedures were a transcervical carotid revascularization, subclavian to internal carotid artery bypass, and transfemoral carotid artery stenting. 8 patients, 10.7%, underwent contralateral revascularization, with the same distribution of procedures as those ipsilateral to occlusions. 2 of the 10 patients with discrepancies underwent carotid endarterectomy, and 1 underwent carotid stenting. Conclusions. In our experience, duplex diagnosis of C.A.O. is associated with a greater than 10% discordance when compared with CSI. These patients may benefit from closer surveillance, as well as confirmatory computed tomography or magnetic resonance angiography. Further work is needed to determine the optimal diagnostic modality for C.A.O. Efficiency and safety of dual pathway inhibition for the prevention of femoropopliteal artery restenosis and repeated endovascular interventions. Objective. There is a lack of consensus regarding the optimal strategy for evaluating the efficiency and safety of dual pathway inhibition, DPI, in preventing femoropopliteal restenosis in patients undergoing repeated endovascular interventions. Despite several therapeutic interventions available for preventing femoropopliteal restenosis post-repeated endovascular interventions, the ideal strategy, particularly evaluating the efficacy and safety of DPI, remains a matter of debate. Methods. From January 2015 to September 2021, patients who underwent repeated endovascular interventions for femoropopliteal restenosis were compared with those who underwent DPI or dual antiplatelet therapy, DAPT, after surgery using a propensity score-matched analysis. The primary outcome was clinically driven target lesion revascularization, CDTLR. The principal safety outcome was a composite of major bleeding and clinically relevant non-major, CRNM, bleeding. To further enhance the rigor, Kaplan-Meier plots, Cox proportional hazards modeling, and sensitivity analyses, as well as subgroup analyses were employed, reducing potential confounders. Results. A total of 441 patients were included in our study, of whom 294, 66.7%, received DAPT and 147, 33.1%, received DPI, with 114 matched pairs, mean age, 72.21 years, 84.2% male. Cumulative probability of CDTLR at 36 months in the DPI group, 17%, trended lower than that in the DAPT group, 32%, hazard ratio, HR, 0.45, 95% confidence interval, C, 0.26 to 0.78, P equals .004. The cumulative probability of freedom from CDTLR at 36 months in the DPI group was 83%. No significant difference was observed in the composite outcome of major or CRNM bleeding between the DPI and DAPT groups, HR 1.26, 95% C, 0.34 to 4.69, P equals 0.730. The DPI group was associated with significantly lower rates of CDTLR in the main subgroup analyses of diabetes, P equals 0.001, previous smoking history, P equals 0.008, longer lesion length, greater than 10 cm, P equals 0.003, and treatment with debulking strategy, P equals 0.003. Conclusions. In our investigation focused on CDTLR, we found that DPI exhibited a significant reduction in the risk of reintervention compared with other treatment modalities. This underscores the potential of DPI as a viable therapeutic strategy in preventing reinterventions. Moreover, our assessment of safety outcomes revealed that the bleeding risks associated with DPI were on par with DAPT, thereby not compromising patient safety. These findings pave the way for potential broader clinical implications, emphasizing the effectiveness and safety of DPI in the context of reducing reintervention risks. Next article is from Surgical Endoscopy. Robotic Heller's myotomy using the new Hugo-Raz system, first worldwide report. Background. Achalasia is a rare disorder of the esophagus characterized by motor dysfunction in the esophagus and relaxation failure of the lower esophageal sphincter, LES. Currently, surgical myotomy procedures are considered the standard of care. Robotic Heller's myotomy, RHM, with fundoplication has been gaining popularity due to documented advantages in the precision of myotomy as well as avoiding the potential reflux following per oral endoscopic myotomy, POEM. To the best of our knowledge, RHM has thus far been performed exclusively by the Da Vinci surgical system. The new Hugo-Raz system offers a unique modular design and an open console which offers better maneuverability and docking options. In this study, we present the first worldwide series of patients undergoing RHM using the new Hugo-Raz platform. Our objective is to propose optimal operating configuration and setup to fully harness the advantages of the unique modular design of this system. Methods. 10 consecutive achalasia patients underwent robotic Heller's myotomy, RHM, with a Hugo-Raz system. We prospectively collected patient data, including demographics, comorbidities, ASA class, Eckert scores, preoperative manometric data, and endo-flip parameters. Additionally, we recorded the docking and total operative times. Results. Between December 2022 and August 2023, 10 patients underwent RHM with a Hugo-Raz system. Patients had a median age of 42.5 years, 60% were female, and mean BMI was 23.2. 50% had achalasia type 2 and 50% type 1. The median preoperative integrated relaxation pressure, IRP, was 24.9. Median docking time was 10 minutes and overall operative time was 129.5 minutes. All patients, except one with acute coronary syndrome, had an uneventful perioperative course and were discharged on postoperative day 2. Conclusion. The Hugo-Raz system is well designed for robotic Heller myotomy. The operative and clinical results are similar to the currently used robotic system, however, the modular design of the system has some differences. These translate to better docking angles and maneuverability as well as console surgeons' ergonomics. Further experience is needed to explore the advantages of the system's modular design and function. Effects of a force feedback function in a surgical robot on the suturing procedure. Background. Currently, widely used robotic surgical systems do not provide force feedback. This study aimed to evaluate the impact and benefits of a force feedback function on the suturing procedure. Methods. 20 surgeons were recruited and divided into young, Y group, N equals 11, and senior, S group, N equals 9, groups, based on their years of surgical experience. The effect of the force feedback function on suturing quality was evaluated using an objective assessment system, A-Lap Mini, Kyoto Kagaku Company, Limited, Kyoto, Japan. Each participant completed the suturing task on intestinal model sheets with the robotic contact force feedback on and off. The task accomplishment time, S, maximal force, Newton, N, applied to the robotic forceps, and quality of suturing, assessed by A. Lap Mini, were recorded as performance parameters. Results. In total, the maximal force applied to the robotic forceps was significantly decreased with the robotic force feedback switched on median, interquartile range, 2.8 N, 2.3 to 3.2, as compared with when the feedback was switched off, 3.4 N, 2.7 to 4.0, p less than 0.001. The contact force feedback function did not affect the objectively assessed suturing score, 18 points, 17.7 to 19.0, versus 18 points, 17.0 to 19.0, p equals 0.421. The contact force feedback function slightly shortened the task accomplishment time in the Y group, 552.5 s, 466.5 to 832, versus 605.5 s, 476.2 to 689.7, p equals 0.851, but not in the S group, 566s, 440.2 to 703.5, versus 470.5 s, 419.7 to 560.2, p equals 0.164. Conclusions. With the contact force feedback function, the suturing task was completed with a smaller maximal force, while maintaining the quality of suturing. Because the benefits are more apparent in young surgeons, robots with a contact force feedback function will facilitate the educational process in novice surgeons. Next article is from Annals of Surgical Oncology. Association between historical redlining and access to high-volume hospitals among patients undergoing complex cancer surgery in California. Background. We sought to determine the impact of historical redlining on travel patterns and utilization of high-volume hospitals, HVHs, among patients undergoing complex cancer operations. Methods. The California Department of Healthcare Access and Information Database was utilized to identify patients who underwent esophagectomy, S, pneumonectomy, PN, pancreatectomy, PA, or proctectomy, PR, for cancer between 2010 and 2020. Patient zip codes were assigned home owners' loan corporation grades, A, best, B, still desirable, C, definitely declining, and D, hazardous/redlined. A clustered multivariable regression was used to assess the likelihood of patients undergoing surgery at an HVH, bypassing the nearest HVH, and total real driving time and travel distance. Results. Among 14,944 patients undergoing high-risk cancer surgery, S, 4.7%, N equals 1,216, PN, 57.8%, N equals 8,643, PD, 14.4%, N equals 2,154, PR, 23.1%, N equals 3,452, 782, 5.2%, individuals resided in the best, whereas 3,393, 22.7%, individuals resided in redlined areas. Median travel distance was 7.8 miles, interquartile range, IQR, 4.1 to 14.4, and travel time was 16.1 minutes, IQR 10.7 to 25.8. Overall, 10,763, S, 17.4%, PN, 76.0%, PA, 63.5%, PR, 78.4%, patients underwent surgery at an HVH. On multivariable regression, patients residing in redlined areas were less likely to undergo surgery at an HVH, odds ratio, or 0.67, 95% confidence interval, C 0.54 to 0.82, and were more likely to bypass the nearest hospital, or 1.80, 95% C 1.44 to 2.46. Notably, Medicaid insurance, minority status, limited English language proficiency, and educational level mediated the disparities in access to HVH. Conclusion. Surgical disparities in access to HVH among patients from historically redlined areas are largely mediated by social determinants such as insurance and minority status. Next article is from Obesity Surgery. Prevalence of morphometric vertebral fractures after bariatric surgery and its relationship with bone mineral density and bone markers. Background: bariatric surgery, BS, can lead to bone loss and an increased fracture risk. Methods: to determine the morphometric vertebral fracture, MVF, prevalence, and its relationship with bone mineral density, BMD, and biomarkers, turnover after Roux-en-Y gastric bypass, RYGB, and sleeve gastrectomy, SG, we analyzed post-surgery X-rays of the spine in 80 patients, 88% female, 51% RYGB, age 41.2, 6.8 years, from 117 participants retrospective cohort, 1 to 2 years, greater than 2 and less than 5 years, and greater than 5 years. We still analyzed body composition and BMD by dual energy X-ray absorptiometry and bone parameters. Results: MVF prevalence was 17.5%, 1480, with no statistical difference between groups, p equals 0.210. RYGB group had a higher prevalence of secondary hyperparathyroidism, SHPT, PTH greater than or equal to 65 pg/ml, 18.4% versus 7.8%, respectively, p equals 0.04, PTH, 61.3 versus 49.5 pg/ml, p equals 0.001, CTX, 0.766, 0.29, ing/ml versus 0.453, 0.30, ing/ml, p equals 0.037, and AP, 101.3, 62.4, UL versus 123.9, 60.9, UL, p equals 0.027, than the SG group. Up to 5 years postoperatively, RYGB had a lower total, 1.200, 0.087, versus 1.236, 0.100, G/cm2, p equals 0.02, femoral neck, 1.034, 0.110, versus 1.267, 0.105, p equals 0.005, and total femur BMD, 1.256, 0.155, versus 1.323, 0.167, p equals 0.002, then SG group. We found no statistically significant difference between the MFE plus and MVF minus groups regarding age, sex, BMI, surgery time, BMD, or bone and metabolic parameters, including leptin. Conclusion: we found a high prevalence of MVF after BS with no differences between RYGB and SG. Can surgeons reliably identify non-cirrhotic liver disease during laparoscopic bariatric surgery? Introduction. Identification of liver disease during bariatric operations is an important task given the patient's risk for occult fatty liver disease. Surgeons' accuracy of assessing for liver disease during an operation is poorly understood. The objective was to measure surgeons' performance on intraoperative visual assessment of the liver in a simulated environment. Methods: liver images from 100 patients who underwent laparoscopic bariatric surgery and preoperative ultrasound elastography between July 2020 and July 2021 were retrospectively evaluated. The perception of 15 surgeons regarding the degree of hepatic steatosis and fibrosis was collected in a simulated clinical environment by survey and compared to results determined by ultrasonographic exam. Results: the surgeon's ability to correctly identify the class of steatosis and fibrosis was poor, accuracy 61% and 59%, respectively, with a very weak correlation between the surgeon's predicted class and its true class, R equals 0.17 and R equals 0.12, respectively. When liver disease was present, surgeons completely missed its presence in 26% and 51% of steatosis and fibrosis, respectively. Digital image processing demonstrated that surgeons subjectively classified steatosis based on the yellowness of the liver and fibrosis based on texture of the liver, despite neither correlating with the true degree of liver disease. Conclusion: laparoscopic visual assessment of the liver surface for identification of non-cirrhotic liver disease was found to be an inaccurate method during laparoscopic bariatric surgery. While validation studies are needed, the results suggest the clinical need for alternative approaches. Efficacy of bowel regimen in decreasing postoperative constipation in bariatric surgery patients. Purpose: postoperative constipation after bariatric surgery is a common complaint, decreasing patient quality of life. No literature exists examining the efficacy of a preoperative bowel regimen in reducing postoperative constipation in this cohort. This study aims to explore the efficacy of a well-established bowel regimen, polyethylene glycol, PEG, in reducing constipation frequency and severity after bariatric surgery. Methods: this was a retrospective study of adult patients undergoing primary and revisional bariatric procedures. The use of PEG bowel prep for bariatric patients was introduced as an institutional quality improvement measure. Patients during the first 3 months after PEG implementation were surveyed for postoperative constipation. For the year after implementation, patients were followed for 30-day emergency room visits or hospitalization secondary to constipation. This cohort was compared to historical controls from the previous year. Student t-tests were used for statistical analysis. Results: during the 3-month exploratory phase, 2849, 57.14%, patients fully completed the bowel regimen. In total, 0.56, 0%, patients reported preoperative constipation, and 528, 17.9%, patients reported constipation at the 3-week follow-up. In the 1-year post-implementation cohort, 234, 0.85%, patients had constipation-related occurrences at 30-day follow-up, compared to 8,219 patients, 3.65%, in the historical cohort, p equals 0.04. Conclusions: the implementation of a PEG-based bowel regimen did not eliminate self-reported constipation. However, there were significant differences in rates of constipation-related ED visits and hospital readmissions, suggesting that the bowel regimen decreases rates of severe constipation. Finally, patient compliance was limited. Future work should aim towards increasing compliance. Next article is from International Journal of Surgery. Comparing the impact of three-dimensional digital visualization technology versus traditional microscopy on microsurgeons in microsurgery, a prospective self-controlled study. Background: emerging three-dimensional digital visualization technology, DVT, provides more advantages than traditional microscopy in microsurgery. However, its impact on microsurgeons' visual and nervous systems and delicate microsurgery is still unclear, which hinders the wider implementation of DVT in digital visualization for microsurgery. Methods and material: 42 microsurgeons from the Zhongshan Ophthalmic Center were enrolled in this prospective self-controlled study. Each microsurgeon consecutively performed 30 minutes conjunctival sutures using a three-dimensional digital display and a microscope, respectively. Visual function, autonomic nerve activity, and subjective symptoms were evaluated before and immediately after the operation. Visual functions, including accommodative lag, accommodative amplitude, near point of convergence and contrast sensitivity function, CSF, were measured by an expert optometrist. Heart rate variability was recorded by a wearable device for monitoring autonomic nervous activity. Subjective symptoms were evaluated by questionnaires. Microsurgical performance was assessed by the Video-Based Objective Structured Assessment of Technical Skill, OSATS, tool. Results: accommodative lag decreased from 0.63, 0.18 diopters, d, to 0.55, 0.16, d, p equals 0.014. Area under the log contrast sensitivity function increased from 1.49, 0.15, to 1.52, 0.14, p equals 0.037, and heart rate variability decreased from 36.00, 13.54 milliseconds, ms, to 32.26, 12.35 ms, p equals 0.004, after using the DVT, but the changes showed no differences compared to traditional microscopy, p greater than 0.05. No statistical significance was observed for global OSAT scores between the 2 rounds of operations. Mean difference, 0.05, 95% C, minus 1.17 to 1.08 points, p equals 0.95. Subjective symptoms were quite mild after using both techniques. Conclusions: The impact of DVT-based procedures on microsurgeons includes enhanced accommodation and sympathetic activity, but the changes in surgical performance are not significantly different from those of microscopy-based microsurgery. Our findings indicate that short-term use of DVT is reliable for microsurgery, and the long-term effect of using DVT deserve more consideration. Next article is from Journal of the American College of Surgeons. Nationwide, county-level analysis of the patterns, trends, and system-level predictors of opioid prescribing in surgery in the U.S., social determinants and access to mental health services matter. Background: the diversion of unused opioid prescription pills to the community at large contributes to the opioid epidemic in the U.S. In this county-level population-based study, we aim to examine the U.S. surgeons' opioid prescription patterns, trends, and system-level predictors in the peak years of the opioid epidemic. Study design: using the Medicare Part D database, 2013 to 2017, the mean number of opioid prescriptions per beneficiary, OPBs, was determined for each U.S. county. Opioid prescribing patterns were compared across counties. Multivariable linear regression was performed to determine relationships between county-level social determinants of health, demographic, e.g. median age and education level, socioeconomic, e.g. median income, population health status, e.g. percentage of current smokers, healthcare quality, e.g. rate of preventable hospital stays, and healthcare access, e.g. healthcare costs, and OPBs. Results: opioid prescription data were available for 1,969 of 3,006, 65.5%, U.S. counties, and opioid-related deaths were recorded in 1,384 of 3,006 counties, 46%. Nationwide, the mean OPBs decreased from 1.08 plus or minus 0.61 in 2013 to 0.87 plus or minus 0.55 in 2017. 81.6% of the counties showed the decreasing trend. County-level multivariable analyses showed that lower median population age, higher percentages of bachelor's degree holders, higher percentages of adults reporting insufficient sleep, higher healthcare costs, fewer mental health providers, and higher percentages of uninsured adults are associated with higher OPBs. Conclusions: opioid prescribing by surgeons decreased between 2013 and 2017. A county's suboptimal access to healthcare in general and mental health services in specific may be associated with more opioid prescribing after surgery. Efficacy of augmented reality combined with indocyanine green fluorescence imaging guided laparoscopic segmentectomy for hepatocellular carcinoma. Background: the internal anatomy of the liver is extremely complex. Laparoscopic anatomical segmentectomy requires reference to the position and alignment of intrahepatic vascular. However, the surface of the liver lacks anatomical landmarks and the liver segment boundaries cannot be identified with the naked eye. Augmented reality navigation, ARN, and indocyanine green fluorescence imaging, PHI, are emerging navigation tools in liver resection. This study aimed to explore the efficacy and application value of laparoscopic anatomical segmentectomy guided by ARN combined with indocyanine green PHI. Study design: 98 patients who were diagnosed with hepatocellular carcinoma and underwent laparoscopic anatomical segmentectomy from January 2018 to January 2022 were retrospectively analyzed. They were divided into the ARN-PHI group, 45 patients, and the non-ARN-PHI group, 53 patients, based on whether ARN combined with PHI was applied during the operation. The differences in intraoperative and postoperative outcomes were compared. Results: there was no significant difference in preoperative baseline data and postoperative complication rates between the two groups. Compared with the non-ARN-PHI group, the ARN-PHI group had much lower intraoperative blood loss, 100 versus 200 milliliter, p equals 0.005, and a lower incidence of remnant liver ischemia, 13.3% versus 30.2%, p equals 0.046. The 1 and 3-year disease-free survival rates in the ARN-PHI and non-ARN-PHI groups were 91.01% versus 71.15% and 70.01% versus 52.46%, respectively, The differences between the two groups were statistically significant, p equals 0.047. Conclusions. The ARN-Phi technology provides a more standardized approach for liver parenchyma section during laparoscopic liver resection, effectively minimizing intraoperative blood loss, reducing postoperative remnant liver ischemia, and improving oncological prognosis. This method is safe and feasible and has good clinical application prospects. Next article is from Journal of Trauma and Acute Care Surgery. Implementation evaluation of tiered tele-triage pathways for burn center consultations and transfers. Background. Early transfer to specialized centers improves trauma and burn outcomes, however, over-triage can result in unnecessary burdens to patients, providers, and health systems. Our institution developed novel burn triage pathways in 2016 to improve resource allocation. We evaluated the implementation of these pathways, analyzing trends in adoption, resource optimization, and pathway reliability after implementation. Methods. Triage pathways consist of transfer nurses, RNs, triaging calls based on review of burn images and clinical history, green pathway for direct outpatient referral, blue pathway for discussion with the on-call provider, red pathway for confirmation of transfer as requested by referring provider, and black pathway for the rapid transfer of severe burns. We used the RE-AIM, reach, effectiveness, adoption, implementation, maintenance, framework to evaluate implementation. These pathways affected all acute burn referrals to our center from January 2017 to December 2019, reach. Outcomes of interest were pathway assignment over time, adoption, changes to burn provider call volume, effectiveness, and the concordance of pathway assignment with final disposition, implementation reliability. Results. Transfer RNs triaged 5,272 burn referrals between 2017 and 2019. By January 2018, greater than 98% of referrals were assigned a pathway. In 2018 to 2019, green pathway calls triaged by RNs reduced calls to burn providers by a mean of 40, SD, 11, per month. Patients in green/blue pathways were less likely to be transferred, with greater than 85% receiving only outpatient follow-up, p less than 0.001. Use of the lower acuity pathways increased over time, with a concordant decrease in use of the higher acuity pathways. Younger adults, patients referred from Level 3 to Level V trauma centers and non-trauma hospitals, and patients referred by APS were less likely to be triaged to higher acuity pathways. Conclusion. Implementation of highly adopted, reliable triage pathways can optimize existing clinical resources by task-shifting triage of lower acuity burns to nursing teams. Next article is from the American Journal of Surgery. The impact of COVID-19 on patients diagnosed with melanoma, breast, and colorectal cancer. Background. The COVID-19 pandemic impacted healthcare resource allocation and utilization of preventative medical services. It is unknown if there is resultant stage migration of melanoma, breast, and colorectal cancer when comparing extended time periods before and after the pandemic onset. Methods. A retrospective cohort study of melanoma, breast, and colorectal cancer patients was completed. Clinical and pathological staging was compared utilizing 12 and 22-month timeframes before and after the pandemic outbreak. Results. Between the 22-month pre- and post-COVID-19 groups, breast cancer clinical stage T2 significantly increased, and pathological stage 2 decreased. Colorectal cancer clinical stage T1 decreased, stage T4 increased, and stage 0 decreased in the 22-month groups. In the 12-month groups, melanoma clinical stage T1 increased, and colorectal cancer clinical stage N2 increased. Conclusions. Evaluating extended timeframes beyond the immediate pre- and post-COVID-19 period revealed significant increases in clinical staging of breast and colorectal cancer, suggesting advanced disease is becoming more evident as time progresses. At-a-risk stratification in papillary thyroid microcarcinoma has low positive predictive value when identifying recurrence. Background. Rising incidence of papillary thyroid microcarcinomas, PTMC, has raised concerns for overdiagnosis. Utility of the American Thyroid Association Risk Stratification System, ATA-RSS, 2015 in predicting risk of disease recurrence in patients with PTMC was assessed. Methods: electronic health records of patients who underwent total thyroidectomy were queried. ATA-RSS 2015 risk stratification was performed on those with PTMC, and validity for predicting disease recurrence was calculated. Results: with 10-year median follow-up, recurrence was higher in PTMC patients with high/intermediate versus low ATA risk, 33% versus 4%, p equals 0.002. Sensitivity of ATA-RSS for detecting recurrence was 60%, specificity 90%, PPV 33.3%, NPV 96.6%, and accuracy 88%. When microscopic extrathyroidal extension, ETE, was excluded as an intermediate risk criterion, PPV improved to 50% and accuracy improved to 92.5%. Conclusions: ATA-RSS 2015 predicts recurrence in PTMC with high NPV but low PPV. Exclusion of microscopic ATA improved PPV, which may help prevent overtreatment. Functional gallbladder disorder, interim analysis of a prospective cohort study. Background: functional gallbladder disorder, FGBD, remains a controversial indication for cholecystectomy. Methods: a prospective cohort study enrolled patients strictly meeting Rome criteria for FGBD, and cholecystectomy was performed. They were assessed pre- and 3 and 6 months postoperatively with surveys of abdominal pain and quality of life, rapid and SF12 surveys, respectively. Interim analysis was performed. Results: although neither ejection fraction nor pain reproduction predicted success after cholecystectomy, the vast majority of enrolled patients had a successful outcome after undergoing cholecystectomy for FGBD. Of a planned 100 patients, 46 were enrolled. Of 31 evaluable patients, 26, 83.9%, reported rapid improvement and 28, 93.3%, SF12 improvement at 3 or 6 month follow-up. Conclusion: FGBD, strictly diagnosed, should perhaps no longer be a controversial indication for cholecystectomy, since its success rate for biliary pain in this study was similar to that for symptomatic cholelithiasis. Larger-scale studies or randomized trials may confirm these findings. Age is just a number. The role of advanced age in predicting complications following ventral hernia repair with component separation. Background: while advanced age is often considered a risk factor for complications following abdominal surgery, its impact on outcomes after complex open ventral hernia repair, VHR, with component separation technique, CST, remains unclear. Methods: a single-center retrospective review of patients who VHR with CST from November 2008 to January 2022 was performed, and cohorts were stratified by presence of advanced age, greater than or equal to 60 years. Results: of 219 patients who underwent VHR with CST, 114 patients, 52.1%, were age greater than or equal to 60 years. Multivariate analysis demonstrated BMI to be an independent predictor for any complication, or 1.1, p equals 0.002, and COPD was positively associated with seroma development, or 20.1, p equals 0.012. Advanced age did not independently predict postoperative outcomes, including hernia recurrence, or 0.8, p equals 0.766. Conclusions: VHR with CST is generally safe to perform in patients of advanced age. Every patient's comorbidity profile should be thoroughly assessed preoperatively for risk stratification regardless of age. Next article is from World Journal of Surgery. Repeat imaging increases detection of delayed pseudoaneurysms in patients with high-grade solid organ injury following abdominal trauma. Background: non-operative management of abdominal trauma can be complicated by the development of delayed pseudoaneurysms. Early intervention reduces the risk of rupture and decreases mortality. The objective of this study is to determine the utility of repeat computed tomography (CT) imaging in detecting delayed pseudoaneurysms in patients with abdominal solid organ injury. Methods: a retrospective cohort study reviewing Montreal General Hospital registry between 2013 and 2019. Patients with the American Association for the Surgery of Trauma, AAST, grade 3 or higher solid organ injury following abdominal trauma were identified. A chart review was completed, and demographics, mechanism of injury, injury severity score, ISS, score, OST injury grade, CT imaging reports, and interventions were collected. Descriptive analysis and logistic regression model were completed. Results: we identified 195 patients with 214 solid organ injuries. The average age was 38.6 years, 28.2% were female, 90.3% had blunt trauma, and 9.7% had penetrating trauma. The average ISS score was 25.4, SD 12.8, in patients without pseudoaneurysms and 19.5, SD 8.6, in those who subsequently developed pseudoaneurysms. The initial management was non-operative in 57.0% of the patients, 30.4% had initial angioembolization, and 12.6% went to the operating room. Of the cohort, 11.7% had pseudoaneurysms detected on repeat CT imaging within 72 hours. Grade 3 represents the majority of the injuries at 68.0%. The majority of these patients underwent angioembolization. Conclusions: in patients with high-grade solid organ injury following abdominal trauma, repeat CT imaging within 72 hours enabled the detection of delayed development of pseudoaneurysms in 11.7% of injuries. The majority of the patients were asymptomatic. Prognostic factors for liver metastasis in patients with small intestinal stromal tumor, a retrospective analysis of surveillance, epidemiology, and end results. Background: liver metastasis, LIM, is the most common distant site of metastasis in small intestinal stromal tumors, cysts. The aim of this study was to determine the risk and prognostic factors associated with LIM in patients with cysts. Methods: patients diagnosed with gastrointestinal stromal tumors between 2010 and 2019 were selected from the surveillance, epidemiology, and end results (SER) database. Univariate and multivariate logistic regression models, as well as a Cox regression model, were used to explore the risk factors associated with the development and prognosis of LIM. Additionally, the overall survival (OS) of patients with LIM was analyzed using the Kaplan-Meier method. Furthermore, a predictive nomogram was constructed, and the model's performance was evaluated using receiver operating characteristic (ROC) curve, calibration curve, and decision curve analysis (DCA). Results: a total of 1,582 eligible patients with cysts were included, among whom 146, 9.2%, were diagnosed with LIM. Poor tumor grade, absence of surgery, later T-stage, and no chemotherapy were associated with an increased risk of developing LIM. The nomogram prediction model achieved an AUC of 0.810, 95% confidence interval, C, 0.773 to 0.846, indicating good performance, and the calibration curve showed excellent accuracy in predicting LIM. The OS rate of patients with LIM was significantly lower than that of patients without LIM, p less than 0.001. Conclusions: patients with cysts who are at high risk of developing LIM deserve more attention during follow-up, as LIM can significantly affect patient prognosis. The nomogram demonstrated good calibration and discrimination for predicting LIM. Thank you for listening to This Week in Surgery, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.